Hi, everybody. My name is Deborah Axelrod, and I am the Director of Community Education and Outreach at the NYU Perlmutter Cancer Center. So this is our breast cancer webinar. It's part two. Last week we did part one. We started off, I talked a little bit about statistics, and we had four exceptional speakers. Well, we're going to continue that with five exceptional speakers. We're going to talk about stage 0 breast cancer that Dr. Helen Pass will present. Dr. Melissa Fana will present on triple negative breast cancer. Dr. Nina Diabrio on metastatic breast cancer. Dr. Anthony Baez, who was here with us last week, he's a repeat, which is great for us, on diversity and inclusion in breast cancer. And Nancy Chan will then round it off with clinical trials and how to find out about them. So I just wanted to run a few things by everybody because we're going to be talking about specifically about different types of breast cancer. And in order to understand how we know about what different types there are, we have to biopsy them. So there are a lot of different ways that we can biopsy. We could do a fine needle aspiration, which is a kind of a very easy way of which is very accessible. It's in our office. We take a needle, we put it in a lump that we can feel, we plate it off on slides, and we have a pathologist look at it right away, and we pretty much have an answer. But we don't really see the architecture. So we like to see the architecture of what we're looking at, not just cells. And that's where the core needle biopsy comes in. And so that the core biopsy is, well, it could be a core under a sonogram, it could be a core under a mammogram or a stereotactic biopsy. It takes a core of tissue out, not just cells. It could also be an MRI core biopsy. And then finally, there's also an excisional biopsy, which we really try to avoid because we like to get all our information without going into the operating room. And finally, there's also the biopsy of distant sites. And that's important because when we talk about metastatic cancer and Dr. Diabrio speaks, she speaks about it because we'll know if there's any cancer at different sites because they've been biopsied or identified on scans. Okay. Non-invasive cancer, which Dr. Pass will kick off with, 20% of all non-invasive cancers, DCIS, LCIS is not a cancer, it's a risk marker. And even today in my office, someone came in tears and was told that she had a cancer, which was LCIS. It is not. Invasive cancer makes up really the majority of what kind of cancer we see, 80%, and it could be ductal, it could be lobular, and there's lots of different subtypes. Breast cancer is really not a single disease, and researchers now have the ability to break down breast cancer into different subtypes based on receptors, and receptors are proteins. They sit on the surface of the cell. We can describe a cancer as having estrogen and progesterone receptor proteins, and about 70% of all cancers have this. And then about 20% of cancers have the HER2 protein cancer gene, and these are, specify a more aggressive type of cancer. So you can see, like on the surface of the cell, all cancers, all cells actually have HER2 receptor proteins, and also they have estrogen and progesterone. But in a cancer cell, you can get a lot of them, and that could really drive, how we treat breast cancer. And HER2 positive breast cancers also have a lot of these and signify, a heightened growth pattern. So let me introduce Dr. Pass. Dr. Pass is currently the chief of breast surgery at NYU Langone Hospital on Long Island. She's very active in national societies. She was a past president of the American Society of Breast Surgeons, a governor of the American College of Surgeons, and a member of the executive committee on the Commission on Cancer, which is a really important part of having a breast center. She also has been very, very active in giving the best highlights of one of our extremely popular professional meetings. So Dr. Pass, please.
Great. Well, good evening. Thank you to everybody who made time to come and talk. I get to talk about the easy cancer, if there is such a thing, which is called ductal carcinoma in situ. You will hear us use the abbreviation DCIS, as Dr. Axelrod said. LCIS, or lobular carcinoma in situ, is a totally different topic. None of these slides at all apply to that topic. And so we're going to focus on the one that starts in the milk duct, and that's what ductal means. So these are cells that are growing in an unregulated fashion, hence the word cancer, but they're confined within the wall of the milk duct, hence the term in situ. This is a very important distinction because, as you can see on the bottom here, a normal duct, no abnormal growth going on. DCIS, these purple cells in the middle of the milk duct, are unregulated and growing out of control, but they haven't burst through the wall of the milk duct. Everybody who's ever had a needle biopsy looks at this slide and goes, oh my God, but when you did the biopsy, you burst my duct open and you turned it into invasive cancer. And I'd like to reassure you, no, that's not how it works. The cells actually have to have the capacity to chew through the wall of the milk duct to get out. It's not that opening the duct spills them and they convert into invasive cancer. And we're very lucky our pathologists can tell the difference. So yes, I believe ductal carcinoma in situ is a breast cancer, but it is not capable of spread. Now, I know nobody is a pathologist here, but on the bottom, you can see these normal milk ducts, single cells. And what's important is the blood vessels and actually the lymph vessels live outside of the milk ducts. And that's why if the cancer is totally confined within the milk duct, it doesn't have the ability to get to the lymph vessels, get to the blood vessels, and therefore it can't spread to the lymph nodes and beyond. We use terms very interchangeably. Medicine's full of jargon, but ductal carcinoma in situ is also known as DCIS, is known as intraductal cancer, pre-invasive cancer, non-invasive cancer, stage 0 cancer, TIS. But I think the best way to really think about it is it's an early breast cancer and a marker of risk for invasive cancer. It also can, if left behind, develop into an invasive cancer. So again, you already saw about 20% of women with breast cancer will be diagnosed with a DCIS. There's currently more than 1 million women living with DCIS and about 50,000 new cases a year in the United States. So does DCIS progress to invasive cancer? And I think this is where some of the crux and confusion about, are we overdiagnosing DCIS? Is it going to sit there and become never a problem, or is it going to grow into an invasive cancer where it's got the possibility of spreading? And so really what we know, and you'll see a very big number depending on which study you look at, anywhere from 20 to 50% of DCIS eventually become an invasive cancer. Well, that's the pessimist view. The optimist view is, okay, 80%, maybe as low as 50%, never will form a problem and become an invasive cancer. And so again, we know that it doesn't automatically, inevitably turn into invasive cancer. And we know that because if we started screening and finding more non-invasive cancer and treating it, the rate of invasive cancer should have gone down, but actually both have increased. We know from our colon cancer and cervical cancer screening, when we find these early polyps and in situ cancer, we are seeing a decrease in invasive cancers later. Our biggest problem, and really the focus of a lot of research right now, is trying to figure out which DCIS is never going to cause a problem and which DCIS will eventually become an invasive cancer, so we can right-size our treatment recommendations. So again, it's usually asymptomatic. Usually people don't have any symptoms from DCIS. Rarely patients will have a mass. Rarely they'll have bloody nipple discharge, but it's usually found as these little white dots on a mammogram, these microcalcifications. Again, not all calcifications are a marker of cancer. So you can have benign calcifications as well, but our radiologists do a very good job of identifying which ones look worrisome to them and which ones are okay just to follow. And then, as you saw, usually we get better pictures, the diagnostic mammogram, or like I tell patients, the squeeze me harder view, usually followed by a needle biopsy, as you've already seen. So I have to put in the commercial that says mammograms save lives. Again, this is what we want to find. We do mammograms to find this earliest non-invasive cancer because when we find it and take care of it at such an early standpoint, these are the ones that women go on to cure. So again, doesn't even need to be treated. If 80 or maybe 50% is never going to become an invasive cancer, are we subjecting women to more treatment? Now, for those of you who don't live in the breast world, these names don't maybe resonate with you, but Mel Silverstein's one of the fathers of DCIS. He's one of the ones that really tried to look at, can we stop treating it? And his conclusion was, we still can't determine between which ones are the bad actors and which ones are the good actors. And so right now, we still like to treat. Dr. Weiner, who's not a surgeon. So again, I always love it when the non-surgeons want to talk about needing surgery. And again, the same thing, because in some cases it develops into an invasive cancer, he recommends treating it. And Dr. Susan Love of the Susan Love Breast book, again, tries to soften it. She's trying to say that DCIS is not going to kill you, but removing it can prevent a problem so that it doesn't come back or turn into invasive cancer. This is my reminder also to myself that says, though, there are under clinical trials situations where we will watch patients. We call it active surveillance. There are some very specific criteria. It has to be well seen on imaging. It has to be usually low grade, low risk DCIS. And in the appropriate setting, monitoring can be happening. And again, we're doing a lot of work on molecular profiling and genomic assays to say, is there a way that we can figure out which ones are going to be indolent and never cause a problem and which ones are going to be more aggressive? So we're really working on that. So is surgery always necessary? Well, almost always. Nothing's always yes or no. It's non-invasive, it's non-life threatening, but because it can turn into something more serious and because we can usually treat it with surgery, if we completely remove it, it won't come back and it won't become invasive. Also, we know about 20% of the time, if we remove DCIS, we will find an area of invasive cancer that the needle missed. And so again, if you're a candidate and can get through surgery safely, we usually think that the benefits outweigh the risk. Two types of surgery, not going to give you the whole surgery lecture, but again, what surgery you get is really dependent on how big is the tumor, how big is your breast, and how safely can we do it. So again, our job is to figure out, would you do better with a lumpectomy? If the area is really large in relationship to the size of your breast, maybe you do better with a mastectomy. Again, we tend not to remove lymph nodes for small areas of DCIS since, as I said, it can't get to the bloodstream or the lymph stream. But like anything, there's exceptions. And usually if we're doing a mastectomy, because there is a larger area at a risk of upgrade, often some lymph nodes will be sampled as well. Okay, what other treatments might be needed? Usually if you have a mastectomy, that area is gone. We don't talk about radiation, often endocrine treatment's not needed. With a lumpectomy, we usually do talk about radiation and endocrine treatment, but not in the same way we talk about it for invasive cancers, because the 10-year survival rate for DCIS is 98%, whether or not you get radiation and whether or not you get hormone treatments. Really what we're trying to do is decrease the risk of a problem down the road. So in brief, let's take a quick look at radiation. So radiation uses high energy beams to kill the abnormal cells, and it reduces the chance that the DCIS will either come back or progress to invasive cancer. The risk really, we stratify it based on patient and tumor factors, and you can see some of the high risk factors. There are some tests that are available that really helps quantify the risk of local recurrence and looks at the molecular profile of these tumors. The DecisionRT and Oncotype DCIS can really help us quantify this risk, but we have to balance it with the side effects, the quality of life. If you look at a list, they also say the time it takes to get these treatments, although sometimes radiation can now be delivered in as little as 5 days, and also really what the patient wants. What's their tolerance for side effects versus what's their fear of recurrence? So for patients with low risk disease, with low scores, we may view radiation as optional. An observation may be optimal. For patients with high-risk disease, younger, larger tumors, high grade, we tend to lean more on the additional benefit of radiation therapy. So what about medical therapy? Again, the disease is non-invasive. It can't spread. So nobody's going to get chemotherapy for DCIS. Endocrine or hormone therapy or anti-estrogen therapy may be appropriate, especially if the disease is estrogen receptor positive, but it's really a hard choice. The benefits are small, mostly prevention of a second cancer, and there are some significant side effects. So I always tell everybody, go meet with the medical oncologist. They're the ones that prescribe these medicines because they're the same ones we use to treat breast cancer, and talk about your specific risk, the expectation of benefit, what they think the side effects will be for you, and really help you balance your decisions that way. So I tell everybody seeing a medical oncologist is mandatory. Taking the drugs is something you will discuss. So again, I really want people to remember that the prognosis with DCIS is excellent. Survival rate is 98%. So this is one of the few things that we say, boy, you can have a cure when we find these calcifications early and get your mammogram. So if it's been over a year since you've had your mammogram and you're of the appropriate age, please go get your mammogram. And afterwards, you'll be followed closely to not only make sure we're watching to make sure this doesn't come back, but also to monitor the other breasts so that since you're at slightly increased risk for making a second breast cancer, we don't miss it. So in the old days, it used to be said if you've had cancer in one breast and the cancer comes back in the same breast, we can't give radiation twice, but we now have learned that that's not the case. And often women who have had cancer in one breast can go ahead and get a second lumpectomy if we think we can do it in a cosmetically pleasing fashion. If you've had cancer in one breast and you get a new cancer in the other breast, we just start all over again. So there's no reason you couldn't have whatever you prefer.
What is considered a good margin for DCIS?
I always tell the patient the best margin is the one your surgeon tells you they're happy with. As surgeons, we argue amongst ourselves. The answer on any of our tests is 2 millimeters. That's like 2 pencil tips. It's really not huge and big. There are times when we want a larger margin because there might be other associated concerning features that we're trying to take out, like some extra calcifications. There may be times when we accept a slightly smaller one because we can't go bigger because we've run into the muscles of your chest wall. But our hope is at least 2 millimeters, not centimeters, millimeters.
But do you need a sonogram if you have a mammogram?
It's not an easy answer either. So if you've had a mammogram and you have dense breasts, you don't have any symptoms, but we're screening, often they say get an ultrasound because we want to see more with the dense breast. If you've got fatty breasts and you have calcifications, the likelihood that the ultrasound or sonogram is going to add much to your diagnostic workup may be limited, and they may choose not to. So like anything in medicine, it's individualized. I think across the board, we say young women with dense breasts and having a screening mammogram benefit from a screening ultrasound. If you have a lump, though, we always say mammogram and ultrasound or sonogram.
Melissa Fana is a breast surgical oncologist and the director of women's health for Suffolk County. She is a chief of breast surgery at Long Island Community Hospital, and we are all part of the umbrella of NYU. So I would like to introduce Dr. Fana. Thank you.
Thank you, Dr. Axelrod, and thank you for your wonderful overview in the beginning, and Dr. Pass for that overview of DCIS. Triple negative breast cancer. To introduce this topic, I just want to reiterate the fact that breast cancer is not this strange entity we don't know anything about. We have a good understanding of it, but it's not a new disease, and it's not a single disease. It's based on abnormal cells. You know, in the height of COVID, there was so much panic out there because it was a disease we just didn't understand. But we do understand cancer, that it is an abnormality of our own breast cells, that something happens internally to become abnormal. The body usually gets rid of abnormal cells, but something happens within our body and those cells are not rid. And they can essentially, two things happen to them. They can live forever and they can have babies forever. I always explain that to my patients. They could duplicate forever. The speed in which they're duplicating tells us the aggressiveness of the cancer. About 75% of all breast cancers, we say, are sporadic, spontaneous. They happen for some reason we don't really understand yet. 7.5%, though, are because of a genetic mutation. This is important, especially when talking about triple negative breast cancer, because we understand that the BRCA1 mutation leads to a high percentage of triple negative breast cancers. So when we see a triple negative breast cancer in the office, we really want to pay attention to family history, genetics. We want to do genetic testing to make sure there's not a BRCA1 mutation because management can change. And 12.5% of all breast cancers have some familial risk. So what is triple negative breast cancer? I know that when I meet my patients who are diagnosed with triple negative breast cancer, many of them have Googled or spoken to other people and they come in with fear and anxiety. But I really feel strongly that illuminating the path that you're about to walk is really going to allow you to overcome this disease. And the more you know and understand, the more you can undertake the treatment that's necessary. So triple negative breast cancer lacks the receptors that Dr. Pass referred to. I like to think of it, and I'll give you a picture later, in terms of when we were younger, because usually breast cancer affects older women, although it could affect young women and it could affect men. But when we used to watch television, we used to do something to the TV if we didn't see a good picture. And usually what we used to do, not with these fancy TVs we have now, but we would move the antennas or put foil around it and the reception would improve. So many breast cancers, most breast cancers have those ears or antennas, which are receptors to estrogen and progesterone, the hormones that really contribute to us being women and allow us to do a lot of things. So when a breast cancer is dependent on those hormones, we say they're estrogen or progesterone positive, and I say they have antennas or ears like a rabbit, and the bigger the ear, the better it is in terms of being able to treat it potentially with a pill, a hormone blocker. But if a breast cancer doesn't have those ears, it will be ER negative, PR negative. That's two negatives. The third negative is a third receptor, which I call feet on a rabbit, because if a breast cancer has the ears, it's a good thing. I could grab it by its ears. If it lacks it, I cannot grab it by its ears by giving a woman a pill. I have to figure out a different way to treat it. If it has feet, though, HER2/neu is the receptor. It will run away from us like a tricky rabbit. And so, fortunately, we do have very specific breakthrough treatments. I remember 2014, it was bigger than the Grammys, bigger than these awards last night, when the FDA approved treatment before surgery for the feet kind HER2/neu cancer with targeted therapy, not chemotherapy. Chemotherapy kills all rapidly dividing cells, but targeted therapy specifically to the feet. We understand that there are opportunities to understand triple negative breast cancer, and more so now than ever before do we understand that even within triple negative breast cancer, there are subsets. And we have opportunities sometimes to figure out truly what a triple negative breast cancer, how it's going to respond, and that will give us information to understand the prognosis or how a person is going to do. So if there is an opportunity to give chemotherapy before surgery, it is an advantage because we can see what happens to the cancer after we have a mammogram, ultrasound, probably even an MRI showing us the size of the tumor, et cetera, if the tumor is 2 centimeters or greater. Or we see a positive node, and we biopsy, and we see it has cancer, and we'll have that patient have a biopsy and have a clip at that time. We have an opportunity to treat with chemotherapy. Chemotherapy can do a few things if given before surgery in those cases. It can shrink the tumor. So if someone wasn't able to save their breast before because they had a large tumor, they could potentially save their breast after the chemotherapy. It could eliminate the abnormal cells, the cancer cells from the lymph node. So if there was a positive lymph node and we were going straight to surgery, we'd have to remove a lot of lymph nodes. And somebody might say, well, that's a great, remove them all. I don't want them if at least one was tainted with abnormal cells. The problem is the more lymph nodes we remove, something called an axillary dissection, there's a higher risk of something called lymphedema, 35% in some literature, even 40%. And that's a chronic condition. And I know that's going to be covered next week. So stay tuned for that. And we do have some things we can do for lymphedema, but truly, it's a debilitating condition for many women who report having it and who we find that has it. So we have made a lot of effort in the field of breast cancer and the field of breast cancer treatment and surgery to reduce surgery or the need to do bigger surgery in the axilla to reduce the risk of lymphedema. So we can do that when we give chemotherapy up front, in many cases, when there's a lymph node involved. But I think the most important aspect of being able to give the chemotherapy before surgery is an opportunity. If we understand that triple negative breast cancer is like this little ticking little time bomb, but we're going to take care of it. So no reason to have anxiety or stress because we are going to treat it with chemotherapy. And like I said, the faster the cells are dividing, the more effective chemotherapy is. Chemotherapy kills rapidly dividing cells. The faster they're dividing, the more effective it is. If we give chemotherapy and then we see what happens when we do surgery, if there's nothing left over, which is called a complete response, we know the person should do better. If there's something left over, which I call like a chocolate covered almond, if there's something left over and that almond is left after all that chocolate melted away from the chemotherapy, we can retest it. And retesting gives us an opportunity for treatment. So this is just a little picture of a hormone positive breast cancer, my rabbit, my cartoon with the ears and the feet. And breast cancer, invasive breast cancer anyway, is most of the time could be ductal and some of the time could be lobular. 10 to 15% of invasive breast cancers are lobular. Now, what is a percent of lobular carcinoma that is triple negative? Very, very small, very small. It's a rare entity. So if we think of the breast and when the structure is inside of it, I don't have a picture here, but I should have included it because the way I think of it is like a broccoli stem where the flower part are their lobules and the stem are the ducts. And so if you cut that on cross section and you see the circles, just like Dr. Paz showed us, of the ducts, it is when the cells are abnormal and break through the shell of the duct that we call an invasive carcinoma. Invasive ductal carcinoma is like the stem of the broccoli or the trunk of the tree coming from the duct. And the flower part will be lobular carcinoma. There can be entities that are mixed, but when we talk about triple negative breast cancer, most of the time we're talking about ductal. This picture is showing us just a picture of ER, PR positive. The bigger the ear, usually the less aggressive the cancer. The body of this rabbit or cartoon also matters. It could be 3 flavors, grade 1, grade 2, grade 3, not to be confused with stage. Grade 1 we call well differentiated. So the cells are abnormal, your own breast cells, but they're not that crazy. The second one is moderately differentiated. The third one is poorly differentiated, high grade. So when I think about triple negative breast cancer, it's usually corresponding to a grade 2 or grade 3 cancer that we know is going to respond really well to chemo. And this is just reiterating triple negative breast cancer in this cartoon. The biology of the cancer allows us to tailor treatment. So we can add immunotherapy. That's a recent advantage that we have to add immunotherapy to the chemotherapy that's given. This is just an example of some chemotherapy, ACT, Keytruda, and like I said, that chocolate covered almond, if we give chemotherapy before surgery and we find that there's something left over, usually, I mean, not usually, but yeah, usually, depending, I guess, on the patient and how they did, but we have an opportunity to add another drug like Xeloda, which is described here. And really quickly, I just want to touch upon surgical treatment options. Now, if the tumor is not greater than 2 centimeters or a positive node, we'll do surgery first, and then we'll treat with treatment afterwards, like chemotherapy and radiation if the person saved their breast. there's the overall survival is equivalent when you save your breast or you remove your breast. And you might ask, if survival is the same, why would anyone remove their breast? Well, they can carry a genetic mutation that puts them at elevated risk for a second breast cancer. They can want to avoid radiation. And usually when you remove your breast, you could avoid radiation. Not always, though. If you have a positive margin, if you have a large tumor, if you have very aggressive features, depending on size and aggressiveness, you might still be recommended some radiation. And depending on how many nodes were affected with the cancer, you may be offered radiation as well. Now, I just want to highlight this, and I'm going to end with this. As a surgeon, it's really exciting. I'm privileged and honored to be a surgeon treating mostly women with breast cancer, some men, because the advancements we've made in surgery are amazing. And it's all about restoring your body and allowing you to restore your life and live a good quality of life where you're not always thinking about what you just overcame. So this is a picture of a radical mastectomy from years ago. And this is a picture of many pictures of one patient. The before is on top, the after. I hope you can see this, but this patient elected to undergo mastectomy. We saved all the external skin, etc. was safe to do so. And her belly tissue, her belly fat connected to an artery and vein was moved and connected to her chest wall vessels. It's called DIEP, deep reconstruction. It isn't for everyone, but for those people who choose to undergo it, it's a wonderful option for implant-based reconstruction. I could show you pictures all day of women who have had breast surgery and lumpectomies who you would never think and never know that they did, and it's important to restore the body. I expect most patients to have an excellent response. It's rare for a patient with triple negative breast cancer because, like I said, the more aggressive the cancer, the more it should respond to chemotherapy. But there are cases where we'll see that we need to discontinue chemotherapy and go to surgery. I would say Dr. Deborah is the best to answer that. But I think in terms of how many people respond, it's much more important to understand how many people completely respond. Like, how many times do we completely eliminate the cancer when we give chemotherapy up front? And with HER2 positive breast cancer, 60 to 70%, there's some studies called Centina, Trifina, exciting information, which we have even more information recently on. It's all about the biology of the cancer and the appropriate patient. It's really about selection. And we as a team with our medical oncology partners select the patients very carefully so that we have a successful response.
What if you're not responding as well? When do you recommend that a patient go back to their surgeon for a reevaluation?
If you ever have a question, if you feel something up, or if you feel that your skin is getting thick or red, any changes on your skin, I mean, it could be a response to the chemotherapy, but you feel a lump, you feel a lump is getting bigger, any question that you have, I regularly see my patients who are on chemotherapy. It's not like I say, okay, you're getting chemotherapy, goodbye, come to me when it's time for surgery. And we as surgeons, I'm sure Dr. Axelrod, Dr. Pass, we regularly see our patients who are on chemotherapy. But if you ever have a question, you reach out to your breast surgeon and be evaluated, because it can happen. It's not that it's impossible. It can happen. It's rare, but it can happen.
So I think it's a very qualified. So to answer your the question about the response rates, we've been able to push response rates, complete response rates, to as high as 68% now with our newest combination therapies based on the immunotherapy that Dr. Fana referred to, the keynote 522. So the patients who got the immunotherapy, that's as high as we can get. It still leaves a proportion of patients, about 20% or so, who 25, 30%, who don't achieve that complete response. So everybody responds a little, but not that complete response, which is sort of the holy grail we're looking for in a lot of patients. But we always have treatment at the back end in case you don't achieve that complete response, so you can improve the outcome. Regarding estrogen, I think it's a nuanced discussion. We do know that women with one breast cancer in general have a higher risk of having another breast cancer in the future if they still have breast, for example. And just because there was a triple negative cancer, it does not completely eliminate the possibility of a second primary that's not estrogen positive. That being said, a lot of our younger patients who have triple negative cancers have the ovaries taken out and choose to have mastectomies, for example. We could consider using that, really to provide a short-term benefit in terms of menopausal side effects. In general, we don't we don't use hormonal therapy for a long period of time. And as you know now, we try non-hormonal options first. There are plenty of them just specifically for hot flashes that can be given in lieu of the controversy in lieu of using hormonal therapy because it's controversial still.
So I had a patient the other day who I had recommended like the new medication Veoza for hot flashes, but I hear it's getting hard to get approved. And I guess it has to get approved because it's very expensive and not, not everybody takes it. It's a non-hormonal medication. Anybody have any experience with that?
Right, we are actually starting some of our patients on the medication. You know, the first thing I usually start off with for hot flashes is a medication called Effexor in a very low dose. It actually can work for some women. And these are, you know, very standard medications that's been around for a long time. There are a lot of different options in terms of how we approach hot flashes. Believe it or not, you know, I actually recommend also our patients to exercise. A lot of time, you know, the vasomotor symptoms can get better as our patients develop a routine for regular exercises. So those are some of the non-pharmacologic approaches to, you know, to treat hot flashes. And, you know, having a conversation with your oncologist is really important because it has to be a tailored approach.
Dr. Diabrio is a medical oncologist, and she is actively involved in breast cancer clinical research. She is the former director of the breast medical oncology program at NYU Langone on Long Island, and has now moved to assume the chief of hematology oncology at the Perlmutter Cancer Center in Brooklyn.
Thank you for having me. And because my colleagues have already laid the groundwork, we'll move very quickly to our next slide. No disclosures. MBC or metastatic breast cancer is also called stage 4 breast cancer. So we've kind of moved from stage 0. You've heard a little bit about a different subtype. And I get to talk about what we call stage 4 breast cancer. It's breast cancer that is spread to another part of the body. Either it could be the lungs, the bone, the brain, liver. Those are the most common sites. The one thing that we know is that even if it spreads to one site or versus two sites or 3, we still call it stage 4 or MBC. So in general, there's no difference in stages, at least clinically. Why does this happen? It happens when cancer cells break away from the original tumor in the breast, travels through the lymph nodes, and then travels through either the bloodstream or the lymphatic system, and then can take root in other parts of the body. And we know that different kinds of breast cancer have a propensity to sort of grow in different organs. We know, for example, HER2-positive breast cancer does have a propensity to have brain metastases, but in general, the bones, the lungs, the brain, or the liver are the most common sites. So what are the patterns of MBC? There's actually 2 different clinical possibilities. One, and the more common type, is actually what we call recurrent MBC, or breast cancer that can come back in another part of the body anytime from a few months to many years after the original diagnosis and treatment, depending on the type of breast cancer. And actually 30% of women who are diagnosed with early stage breast cancer develop metastatic disease. 70% don't, which is a good way of thinking about it, but we certainly see a higher proportion of metastatic disease come back early in more aggressive types of cancer, triple negative, for example, or HER2, which is obviously something that we are, as medical oncologists, are very wary of. And most of our treatments are designed to kind of lower that risk of both early as well as late recurrences. And the much rarer is what we call de novo metastatic breast cancer, or new metastatic breast cancer from the Latin. It really means that at the first time the patient is seen, the cancer has already spread. And thankfully, this incidence is still very low. It's only 6% of breast cancer actually presents as stage 4 right from the outset. Now, one of the things that's hard to tell patients sometimes is, we always put a lot of emphasis on the word cure. It can mean different things to different people. And I always tell people it could be semantics. You could be living a completely healthy, normal life with cancer. So while we say there's no cure for metastatic cancer, which means we can eliminate every single cell, treatment actually can control it for a lot of years. And as I'm hoping to show you in the next few slides, we've moved that envelope a lot with our therapies. So there are a variety of new treatment options, new medicines every day. And really our goal of our treatment is to give patients the best quality of life for as long as possible. So as again alluded to earlier, we treat all breast cancer and specifically metastatic breast cancer based on the subtype. There are 4 clinical subtypes that you've heard of already. The estrogen positive subtype, which is comprises about 60 to 75% of breast cancer. Then there's that HER2 subtype, as Dr. Fana was mentioning, and the HER2 subtype can either have estrogen positive or estrogen negative, and then the triple negative subtype that you heard about, which is less common. And this is what those rabbit ears actually look like under the microscope to our pathologist. This is how they stain the cells and can tell you whether or not the cancer is either estrogen positive or estrogen negative or HER2 positive or negative. But as Dr. Fana was, and we usually refer to estrogen or progesterone positive as hormone positive. You may also hear HR positive, and certainly on lots of ads on TV that mention HR positive breast cancer, and that's really where this comes from. There's a new category that we've started to define, what we call HER2 low. So as Dr. Fana's slides showed you earlier, almost all breast cancer cells have some HER2. When it's strongly positive, what we call 3+, those were defined as HER2 positive. But we do have patients that are 1+ or 2+ and a negative for something called the FISH, which is a confirmatory test. Those are now being defined as HER2 low. So not completely negative, but HER2 low. And that's a very important category because we do have treatments for these patients. One of the most important things about metastatic breast cancer, especially when it's recurrent, is we always rebiopsy. We biopsy a site in the liver or the lung or the bone when it comes back, because sometimes, and it can vary between, as you can see, 32% of the times, 41 and 15% of the time, patients can change their status, which means if the cancer was originally estrogen positive, when it recurs, it might be estrogen negative, and that may be because there's a resistant clone that kind of came back. And the same thing can be seen also with the HER2, which is very important because our treatments are really dependent on what that status is. So very quickly, the current standard for frontline therapy on the left side of your slide is hormone therapy, which you have heard of, the tamoxifen or the aromatase inhibitors, in combination with these drugs. Now, I have included some of the trade names here because they're familiar to you. Ibrance, Kisqali, and Verzenio are the current CDK inhibitors that we use that help the endocrine therapy work for longer and work better and reduce resistance. And we know that just on their own, endocrine therapy works really well. Just for context, I put down PFS, or progression-free survival, how long someone is on a treatment before their cancer starts to grow. And as you can see, when Ibrance was added or 2 aromatase inhibitors, that went from 14 to 24 months. One of the more important things we look at in oncology is overall survival, how long somebody lives before starting, while they're on treatment. And that's also a testament to how toxic some of the treatments are. If you live longer, maybe that's not because you're having toxicities from the treatment. And out of the 3 CDK inhibitors, the ribociclib is the one, the Kisqali is the one that currently shows overall survival data, while the others have not shown a statistical significance, though abemaciclib still gives you about a 13-month benefit. So we're not totally sold that we only have to pick one CDK. It also depends on the side effects for an individual patient. So in general, all 3 drugs are fairly standard for use. Once the cancer progresses or gets resistant, in general, we oncologists will use something called NGS, or next generation sequencing. Either we look at a biopsy or another biopsy, or we look at the blood. And we look for mutations that evolve that make the cancer resistant. One of them you've probably heard of is the PIK3CA mutation. There's a drug on the market called Piqray. Piqray, in combination with another type of estrogen blocker, Faslodex or fulvestrant, is what we would use in patients who have this mutation. Unfortunately, a lot of side effects, especially high blood sugar, a lot of fatigue and nausea with this drug. So it may not be something that everybody can use. Luckily, we now have another drug in the same field called the TrueCap or capivasertib, which not only looks at the PIK3 mutation, but 2 other mutations in the same pathway called the PAM pathway. So there are 3 mutations, all of which capivasertib can target. In some patients, they develop a resistance to the estrogen-driven path. They can no longer be on the aromatase inhibitor because they develop a resistance called an ESR1 mutation. An ESR1 mutation makes that estrogen rabbit ear active all the time. And because it's active all the time, if you use an aromatase inhibitor, it's really not going to help block it. And so there's another class of drugs called oral SERDs, estrogen degraders. And the first of its class that is now approved is a drug called Orserdu, which we have been using in patients who progress after they've received their frontline therapy. Less common targets are women who have a BRCA gene, high what we call tumor mutation burden and other rare mutations for which there are drugs on the market, much less common. And we also have medications for if there were no targets that we could identify today. More and more, we're finding these targets. And there are drugs like Afinitor, which we can combine with hormonal therapy. And once we exhaust our estrogen blocking options, we then move on to either chemotherapy or a new class of drugs that you've heard of, and antibody drug conjugates everywhere on the market now can be used across tumor types on HER2 and Trodelvy. Those are the big ones that are on the market right now. So where does the future go? As I had alluded to, we might be seeing these SERDs, these new drugs, in combination with existing drugs like Ibrance. So we might be combining, for example, Orserdu with Ibrance and making them work longer. We might be seeing new antibody drug conjugates, and they might be drugs that target specific PIK3 mutations, which cause less hyperglycemia, less high blood sugar. So this is a 3-drug combination that was just discussed at this major meeting that we had in Texas in December that we all attend. And this is looking at a 3-drug combination, but much less toxicity in terms of high blood sugar, even though it's targeting a PI3 kinase, but it's for a specific mutation. Moving on to hormone positive or negative HER2 positive breast cancer, again, a different class of drugs. Here, we're trying to block the HER2 receptor. And right from 2013, our standard of care has been using a single chemo called Taxotere in combination with 2 HER2 blocking antibodies, non-chemo drugs called Herceptin and Perjeta. And using that, we've seen that 37% of patients with HER2 positive metastatic or stage 4 breast cancer were still alive at 8 years. So while it might not seem like great numbers, adding trastuzumab and Perjeta have certainly moved the envelope where you can, patients are going longer and longer, even with stage 4 disease. Unfortunately, some patients do get resistant. That's where we have these second-line therapies, one of which is an oral pill called Tukisa in combination with a chemo called Xeloda and Herceptin. And then the other is this antibody drug conjugate, which transcends the tumor subtypes called Enhertu. And one of the things that is really important about these drugs is they are also active in the brain, because a HER2 positive cancer does have a propensity to come back in the brain. And a lot of our treatments don't penetrate the brain, but these do. The progression-free survival, the chance that cancer would come back, was markedly increased to 28.8 months compared with another drug called Kadcyla, which used to be the front runner, but now has moved to a lower, a tier in terms of treatment. So we can have many choices. And for some patients who can't tolerate chemotherapy, we sometimes combine estrogen blocking therapy with the Herceptin, trying to block the ears and the feet at the same time using these different markers. So where does the future lie? Well, more of the same, but because we have such a great, PFS, progression-free survival with this drug on HER2, we're seeing a study that's ongoing that might actually replace this regimen that we've used since 2013 and might actually be the front runner. So we might have a non-aggressive chemotherapy option for our metastatic patients. We might have a completely chemo-free option where we're combining the aromatase inhibitor along with Ibrance and Herceptin in triple-positive cancers. We might be adding immunotherapy because so far we have not really seen immunotherapy as commonly accepted triple-negative cancer. And we might be seeing these smart combinations where we take an oral pill and we use a receptor blocker at the same time to block the HER2 receptor better. Moving on to triple-negative breast cancer that Dr. Fana has talked about in the early stage setting. For metastatic triple-negative breast cancer, as the name suggests, we don't really have those markers. We don't really have those years to block. So what have we done in this situation? We do know that this is the one cancer which is highly dependent on our immune system for growth. The immune system doesn't really recognize these cancers. And so we use an immune marker called the PD-L1 marker to decide who gets immunotherapy or not. So very large studies have shown that if you had a triple-negative metastatic cancer, if you had a high PD-L1 level, then those patients actually benefit from an immunotherapy called Keytruda in combination with chemotherapy. And the median overall survival, these patients were living 2 years and longer with the addition of this pembrolizumab compared to just chemotherapy. Unfortunately, if the PD-L1 is negative, we still currently use chemotherapy, but this is where clinical trials make a huge difference for our patients. But even with just chemotherapy, the survival was actually 17 months in both groups. So even though the immunotherapy didn't help, patients did get a fairly long survival and then moved on to the next therapy. In terms of second-line therapy, as we have alluded to, there are patients who have the BRCA mutation, and this is seen much more commonly in triple negative cancer. We have oral drugs called PARP inhibitors that can be used to block the BRCA in these patients. These antibody drug conjugates can also be used in patients who are HER2 negative and triple negative. And there's always traditional chemotherapy that can still be used. So the future really lies in new combinations. We're looking at smarter ways of deploying chemotherapy better with new antibody drug conjugates. And we're also looking at other types of blockers for triple negative. Maybe they have an androgen receptor like our men with prostate cancer. Maybe it's not all about the estrogen receptor being negative. There are also vaccine trials ongoing in this space in particular. So the therapies that can be used in more than one subtype, even though we've been talking about subtypes all along, are where the mutations are found across subtypes. So you could have an estrogen positive cancer that is BRCA positive, and a PARP inhibitor might be helpful there. Somebody might have an NTRK fusion mutation, very rare, but if you do, we have a drug that blocks that. If you have something called a high mutation, tumor mutation, which is about 5% or under 5% of breast cancers, regardless of whether you're triple negative or estrogen positive, maybe an immunotherapy might be an option. And then finally, this big class of antibody drug conjugates, which I think is really revolutionizing oncology in general, because we're minimizing the use of chemotherapy. So antibody drug conjugates work in two ways. They are like a targeted missile. They have an antibody that they target, like the HER2, but they also have a low dose of chemotherapy attached to be a linker. So they bind to the target, they release the chemotherapy, but some of these also diffuse back in the surface and kill cells around, what we call the bystander. So for example, if you have a HER2 low cancer, all you need is a little bit of HER2, and the antibody can be directed towards it, can diffuse back and kill cells that are traditionally not HER2 positive. So that's the beauty of having these antibody drug conjugates that can combine chemo along with and cause less side effects than traditional chemotherapy. So moving on to, I've spoken a lot about treatment. The question is, can we detect recurrences early in the first place? Can we, in some ways, reduce the incidence of having metastatic disease, those 30% of patients who have metastatic disease? So the gold standard is really looking at scans. We don't just do scans, and usually they're done when you have symptoms. We have a fine threshold for triple negative HER2 cancers in the first 5 years, because that's when they tend to come back. But estrogen positive cancers can even come back later. So it's really being vigilant about your body. We know that tumor markers are often ordered, but they are not sensitive or specific. You could have very high levels in somebody without cancer, or you could have very low levels and have widely metastatic cancer, but they're good adjuncts for monitoring of metastatic cancer. And the new kid on the block is ctDNA, or circulating tumor DNA. So this is detecting tiny little bits of the tumor DNA floating in the bloodstream. We know that's how cancer spreads. We know that these little cancer cells can persist before they before they're visible on a scan. And so we know now that by using ctDNA, we can actually track which patients are more likely to recur. Unfortunately, so far, we have no evidence that if you find somebody with a higher ctDNA and you change treatment, you can actually lower the chance of recurrence. We don't have that data yet, but there are several ongoing studies that are looking at doing that. So for example, if somebody had stage 3 cancer and had a ctDNA monitored, if it was elevated, these are the studies looking at changing treatment at that point, and instead of waiting till it becomes evident on a scan. And so more to come in the years ahead. So can it be cured with all this information? So the answer is not yet. There's certainly long-term durable control. The big question that comes up, what if you have a scan and everything's gone, you can't see anything? Can we stop treatment? And the answer is not yet. And this harkens back to the point that the bloodstream is what harbors these tiny cells. So you may not see everything on a scan. So how you define the control is important. Is it just by a scan, or via something that's much more sensitive, or circulating DNA monitoring? There is a study that's looking at this in the HER2 space. We know some patients with metastatic HER2 disease can have wonderful results and can remain clinically cancer-free on a scan after a few cycles. So this is asking the question, if 3 years have gone by, can you suspend the treatment, even with stage 4 disease, and monitor ctDNA levels to decide when the treatment should be restarted, or do these patients recur earlier? So that's something that's, again, a research question, but it's going to move the needle forward again for metastatic disease. And then the question that's very pertinent to today's discussion especially is, does surgery have a role in somebody who has stage 4 disease already? Is there any point in doing breast surgery when it's already spread? And the answer is there is a role, and generally it's for control of the disease locally if there's pain or bleeding. So moving to a little deeper into where the role of surgery is, and why don't we just do this breast surgery if it's already spread? We know that there are many observational studies. Studies have shown that, just by observing women on large studies, where it seemed as though there's a benefit if you took the breast out, even though there was a stage 4 disease. As you can imagine, a lot of these patients were on studies, who were on these studies were healthier women. Maybe they had a lower risk cancer. So there was always that bias. The best way to do studies in oncology is what we call randomized trials, where there's no bias. 50% gets an intervention and 50 doesn't. And unfortunately, a lot of these, several of these studies, and the largest one in the United States being the ECOG 2108 study, actually showed that for these patients who came in with breast cancer, metastatic breast cancer, had a good response, if 50% had surgery to actually take care of the breast primary, there was actually no improvement in overall survival compared to those patients who just continued on their systemic therapy. So currently, it's not standard to offer what we call curative surgery for the breast in patients who are responding well to metastatic cancer therapy. What about removal of the other metastatic sites? So one of the thoughts is, hey, you've taken the breast, done the surgery, you've treated the cancer well. What if there's a spot in the liver or a spot in the lung? Shouldn't we just go and take everything out that you see on a scan? So one of the studies that answered this question for us was the NRG BR002 study that put this to the test, again, in a randomized fashion. And it looked at patients who had what we call oligometastatic disease, no more than 4 spots of disease elsewhere, and but they excluded brain metastases. They received about 12 months of treatment, whatever you chose to give them for their subtype of cancer. And then these patients had the surgery for the breast, as well as they also had surgery or radiation to treat a liver spot or a lung spot. And unfortunately, these local interventions actually did not improve survival compared to patients who just continued their systemic therapy. Next slide, please. So is that a closed book? Well, the answer is not quite yet, and maybe not standard for curative purposes, but we all have patients where we think differently. Maybe patients who present with metastatic disease, the 6% that I talked about, are different from where the cancer comes back after many years, where it becomes more resistant. And so there are several studies trying to classify patients into, patients who have metastasis in one area versus several areas. And so I think the book is not yet closed on this question, but as of now, it's really for palliative purposes mainly. So in summary, it's not a curable illness yet, but women are living longer and very fulfilling lives with therapies. The subtype really directs the therapy, and biopsies may be done several times, including blood-based biopsies, so we don't have to stick a needle into every time there's a recurrence. Systemic treatment medications are still the mainstay of therapy. Surgery is mainly palliative, but there may be situations where we could talk about it. Aggressive symptom management is very key for our patients because we're really in for the long haul. And for those unfortunate patients where we do end up using a lot of treatments, very early referrals to our palliative care providers can help maintain good quality of life. And a very, very important thing is enroll in a clinical trial if available, because that's the only way we can move the needle even further. So in general, the answer is no, we don't need to screen people. And the thinking used to be that if you have one incurable illness that you're going to be on treatment all the time, there would be no point in going back and looking at the breast and trying to find another cancer. I would say that's a nuanced discussion. We sometimes have patients who go 10 years and beyond, and they are living very healthy lives. And so sometimes we go back and look to see if there's a different cancer. But in general, we don't do it for patients with widely metastatic disease who are already on therapy. We do not need screening mammograms.
Our next speaker is Dr. Anthony Baez. Dr. Anthony Baez has been our breast fellow, our #1 pick. Fantastic. We've been super lucky having him with us this past year. And he's going to talk about diversity and inclusion.
Good evening, everybody. It is a pleasure to be back here another week. Last week we discussed nutrition, and today we are going to dive into a different topic, and yet there will be slight overlap. We are going to start by reviewing breast cancer statistics and trends, and then we are going to discuss breast cancer care disparities, and then we are going to talk a little bit about diversity and inclusion efforts. This slide might be a bit redundant, but breast cancer affects 1 in 8 American women in their lifetime. And it is the second most lethal cancer in women. Thankfully, due to advances in detection and treatment, the mortality rate has decreased significantly in the last 40 years. And when we look at trends in breast cancer, so there are differences in regards to race and diagnosis. So Black women have a higher incidence of diagnosis of breast cancer before age 45 compared to white women. And white women have a higher incidence of breast cancer detected at ages 60 to 84. Hispanic women in general have lower rates of breast cancer compared to white women, but are often diagnosed at later stages. And Asian women have the lowest rate of the disease as well as the lowest death rates. So this slide really looks at 3 graphs from the CDC website, and basically it shows us that initially, when we look at the starting point here is 1999, there seemed to be a slight reduction in the rate of breast cancer in white women. However, this reduction was not seen in Black women. We do know now that in the recent years, there is an overall trend to increase in rates of breast cancer, about 0.5% per year. So this takes us to the topic of healthcare disparities. So mortality rates do differ among different ethnic groups. And Black women are more likely to die from breast cancer at every age. And there is not one reason that we can pinpoint as being the ultimate causative factor, but rather there are multiple reasons that suggest could play a role, such as socioeconomic status, later diagnoses, biologic and genetic differences, as well as differences in access to healthcare. And something that is very important and has been emphasized already in this seminar is that not all cancers are the same, and tumor biology really matters. So Black women are more likely to be diagnosed with triple negative breast cancer, which is an aggressive subtype that Dr. Fana most recently discussed. And there's no exact explanation for this, but there are many different possibilities that have been investigated, including environmental factors as well as biological factors. So there have also been studies that have been performed looking at differences in behaviors and beliefs. And what we've learned is that Black women rely more on breast self-examination as an effective screening tool, as opposed to mammography compared to white women. Black women are also more likely to avoid mammography due to fear of discomfort, embarrassment, or fear of radiation. Black women are also less likely to seek surgical options, which is really an important part of treatment of breast cancer. And a lot of this, it stems from historical medical mistrust. So when we look at outcomes, so we know that overall the outcomes for breast cancer have really improved dramatically across all ethnic groups. However, if we look at 5-year overall survival, it is 92% in white women and 81% in Black women. So despite all these advances, there's still a significant racial gap. And some of this may be attributed to conditions such as poverty, which is associated with underrepresented minorities. And patients who come from impoverished backgrounds have significant disadvantages in education, screening, access to primary care, ability to take time off from work in order to have screening or attend doctor's appointments, as well as barriers to health insurance and other things such as healthy nutrition and exercise. And then, as we've learned multiple times already through this webinar, genetics plays a very important role. And I won't go into all the genes, but there are multiple genes that have been linked to breast cancer. And we know that genetics plays a tremendously important role in the diagnosis, but also the treatment of breast cancer. However, the rates of genetic testing amongst underrepresented minorities is lower compared to other patients. And when we look at genome-wide studies, which have also been very important in pushing the envelope and really pushing forward the field, it appears that currently they are represented by 79% of European participants, which is quite an overrepresentation considering that this only comprises 16% of the world population. So when we look at genetic testing and genetics in general, we really need to think about it as a continuum. And along this continuum, there are different points where we can lose patients if they don't have adequate support or resources. So it starts with first identifying high-risk individuals, assuring that they have appropriate access to genetic counseling and testing, also encouraging uptake of genetic testing and delivery of the genetic testing and counseling, and then there's follow-up care. So we really can see here that there are multiple steps to this and really different points where patients can really fall off the ladder. So then this brings us to how do we solve the problem? And it really comes down to health equity. So if you look at the graphic on the right, this is a good way of really understanding the difference between health equity and equality. But essentially, what we mean by health equity is that everyone should have the same opportunity to maximize their health. So there are different strategies that have been created and different initiatives in order to improve this. And it really all starts from research. So research allows us to identify the problem and better understand the problem by understanding socioeconomic, genetic, and cultural differences that are contributing to the issue. And then it is important to also advocate for preventative strategies that improve modifiable risk factors, such as diet and exercise, which I discussed last week, weight loss programs, and minimizing alcohol and tobacco exposure. Also, advocacy for health equity and patient resources in order to allow them to improve screening and detection, as well as access to treatment, is very important in our mission to improve diversity and inclusion. And then, of course, representation in medicine and healthcare also plays an important role. So when we look at clinical trials, so historically, clinical trials had overrepresentation of patients or participants of European descent. And in fact, when we look at current trends, it appears that Black and Hispanic patients still have lower participation rates in national trials. And this is a problem because it limits our ability to generalize these studies, but it also slows the progress in terms of outcomes in these groups. And the discrepancy does not appear to be related to an unwillingness to participate. So we've learned that in order to improve representation, we must focus on patient education, as well as ensuring comprehension of the educational material that we are delivering to them. It also requires us to improve access to healthcare and participate in community outreach programs, such as the one that we are part of today. And then representation in medicine. So when we look at the United States population, approximately 12% is Black and 18 or 19% is Hispanic. But when we look at the medical student body in the United States, there's definitely a difference here, and only 8% is comprised of Black students and about 7% Hispanics. So there was a study in 2010 that showed that non-white physicians cared for over 50% of minority patients and over 70% of non-English speaking patients. So despite the fact that physicians of minority backgrounds are the minority, they are still caring for the majority of minority patients. So there have been different committees and societies that have been created in order to address this issue. And there have been different diversity requirements that have been implemented and things that have really contributed to improved mentorship and sponsorship for people who are interested in pursuing healthcare careers. And then there have also been institutional policies also here at NYU in order to improve diversity and inclusion. So when we look at NYU, our institution, we see that there have been many, many different strategies that have been implemented, and it starts in the medical school. For example, there's a liaison program in order to help prospective medical students by teaming them up with a faculty of underrepresented minorities. There's also multiple different funds available to patients in order to help with outreach and recruitment. And then there's also targeted outreach and recruitment in the larger faculty, and also a strong commitment to the community. So this is a screenshot of the diversity section of our NYU Langone Health website. And here you can learn more about the different strategies that are being implemented in order to improve our mission to enhance diversity and inclusion. And this is something that we are all very, very proud of.
Dr. Nancy Chan is going to be talking about breast cancer clinical trials and research updates. Dr. Chan is a breast medical oncologist and the clinical research director for breast cancer at the Perlmutter Cancer Center.
Thank you. Thank you. I'm really honored to be here tonight, and thank you for staying on on a workday evening. So many of the talks that came before me from my colleagues have touched upon clinical trials and the importance in advancing breast cancer treatment. So I'm really happy that I'm able to talk a little bit more in detail. So here are my disclosure. I don't have any financial disclosure, and I will be discussing some agents from clinical trials that have not yet been approved. As we all know, breast cancer is the most common type of cancer diagnosed in women, even ahead of lung cancer. In recent years, as Anthony also described, there has been a decrease in breast cancer death, and this is due to a combination of early screening, improvement in surgical, radiation, oncology, and also in systemic treatment from the med-onc realm. I want to dial back a little bit. Just about 2 decades ago, this is the U.S. National Institute of Health Consensus Panel in 2000, that chemotherapy should be recommended for majority of women with localized breast cancer, regardless of lymph node, menopausal, or receptor status. Because at the time, what we had was chemotherapy, and it was recommended widely for women. If you had a breast cancer that was greater than 1 centimeter, you were more likely to receive chemotherapy. But you will see that in this study published in 2000, around the same time, we began to utilize genomic assays and take advantage of the advances in molecular biology. And so now, even in 2000, we began to paint portraits of breast cancer through the molecular lens and better describe and profile the breast cancer subtypes. So today I will talk a little bit about using genomic assays in early breast cancer and how it has reshaped the landscape of breast cancer treatment. So one of the most important genomic assays is the Oncotype DX. It is a 21 gene assay that looks at proliferation, invasion, it looks at HER2 and ER status, amongst other reference genes as well. And how has it shaped how we treat breast cancer? So the Oncotype score gives you a score that is divided into 3 categories: low score, intermediate score, and high score. So if you have a low recurrence score, you have a low, what we consider a low genomic risk tumor, and you're unlikely to benefit from chemotherapy. And if you had a high recurrence score, a score that's greater than 25, then you are more likely to benefit from chemotherapy in addition to anti-estrogen therapy. For a long time, we did not know what the intermediate group with a score 11 to 25, what to do with them. And so for a very long time, these patients all received chemotherapy. But as all of my colleagues have described, when we have a very relevant clinical question about how we should be treating certain subtype of breast cancer, really the definitive way of determining what is the right thing to do for a patient is to conduct a randomized trial. And so this is the TAILOR-X trial that randomized 10,000 women. So this was a huge study. And we found that 70% of patients actually had genomic scores RS of 15 of 11 to 25, 70% of women, so majority, had a score that fell in this intermediate range. And again, majority of these women were recommended chemotherapy. So this study looked at how did the 2 groups who either received chemotherapy or didn't receive chemotherapy do, and how do they compare with each other. So these are the invasive disease-free survival and distant disease-free survival curves. It looks like each graph has only one survival curve, and that is because whether you received chemotherapy or not, you had a similar survival. And therefore, the conclusion from this large clinical trial is that the majority of intermediate risk patients can safely avoid chemotherapy. This was a transformative clinical trial, which saved many thousands and thousands of women to come from systemic chemotherapy that they really didn't need. And this was only able to be determined through clinical trial. This is a clinical trial that we just opened. It is the investigation of serial studies to predict your therapeutic response with imaging and molecular analysis. So essentially, this is utilizing the imaging tools and genomic assays to help us develop a personalized treatment plan for our patients with early stage breast cancer. This is a slide that describes all of the sites that the study is open across the country. Majority are major academic centers because as we know, it really requires the whole team with our surgeons, our radiologists, and medical oncologists, and radiation oncologists to work together. And this is really a complicated trial that can only really be conducted at comprehensive centers. And just as an update, over 2,000 women have already been treated on this study. So this is a really large study that is ongoing. What the study is able to do before a treatment is assigned to a patient is to assess the using genomic tools to assess response predictive subtypes. So further dissecting out whether some patients may benefit from immunotherapy or DNA damaging therapies in addition to the standard therapies. So I think of this as profiling the enemy. We are getting more and more refined information on the tumor that we are treating, and therefore we're coming up with more targeted therapy and more refined treatment options. So again, this is another diagram that's describing what this trial essentially is trying to accomplish. So on the left side here is describing more tailored therapy, so targeting therapy with less treatment, meaning less systemic chemotherapy, less toxic therapy. The treatment strategy is really decided based upon the genomic information we get up front. Currently, if a patient needs therapy before surgery to shrink the tumor and enable our surgeons to perform a successful surgery with clear margins, we tend to not even have any of these genomic information up front. So this is one transformative way of this clinical trial to utilize genomic information on a tumor and designing and assigning a treatment that is more tailored with less chemotherapy. And so in describing clinical trials, how does it benefit a patient? So I want to talk actually about a patient of mine who in 2000 at age 25 gave birth to her daughter. 2 years later, she was diagnosed with a stage 2 ER-positive breast cancer. It was a high-grade invasive ductal carcinoma, so she received chemotherapy, adjuvant endocrine therapy with tamoxifen. But she developed metastatic disease 4 years later. So at this point, her daughter was only 4 years old. And she developed bone disease that was biopsy and confirmed. So she was placed in the next almost 20 years, about 7 lines of different types of therapies. What she's on currently, if you fast forward, is pembrolizumab plus chemotherapy. And so each line of therapy that extended her survival enabled her to work full time and also see her daughter grow up, who she just saw her daughter graduate college this past summer. And so each one of these agents was developed through clinical trial. And so when she did enroll on clinical trial, it was early access to her to get the benefit of a potential life extending agent. And so this is why I want to highlight her history as a way to see how to answer the question, how can a clinical trial help a person? And so when anyone receives the diagnosis of breast cancer, these are some of the questions that we should be thinking about. Should I consider a clinical trial? And how will a clinical trial benefit me? And who should I talk to about clinical trials? So here at NYU, we have a breast research team that is designated to patients with breast cancer of all stages and all different subtypes. We have a large panel and portfolio of clinical trials that are tailored really to the stage and type of breast cancer you have. And so the team are well versed in different protocols and rationale of why we select certain trials and really essentially match a clinical trial to your disease. So sometimes standard of care is the best treatment option for you, but sometimes a clinical trial may be, and you would not know without asking the question. So really, I think it's important to always keep this in the back of your mind and ask your clinician when you're thinking about a new treatment option. And I want to end with this quotation from 1896, Sir George Beatson. He and I And all of us here share the same hope. We share the hope that a solution of the true nature of cancer will be found. And we are getting closer and closer, as Dr. Diabro mentioned, that although stage 4 breast cancer is not yet curable, but we are getting closer as we have better tools and improved technological advances. And we want to harness all of these tools to work toward this common goal that we have to cure breast cancer.
Thank you very much. Hopefully you guys who are on will tune in next week, which will be our last session for the year.